Okay, so today's focus is going to be kind of multifaceted. I want to talk about pH again, but instead of acidosis like I did last time, this focus is going to be on alkalosis. Next, I want to talk about the complexity of the compartments of the body. Then, we're going to tie in some electrolytes. And of course, we'll give some examples involving more than one part of the body, more than one system. And then I guess I'll summarize, and throughout, if I think of a couple things that are cool to add that I didn't include here, I might just do that. So, just a quick reminder, pH. Negative, log, base 10, scale, whatever. The basics of the pH are your body needs to do this thing where it operates in a very finite pH range of 7.35 to 7.45. That's in the blood, which is also called the extracellular fluid. Intravascular volume, but just we're going to lump this all into extracellular and intracellular. And then the intracellular is slightly more acidic, 7.0 to 7.3. And this is intracellular. Now, this is important because of all the compartments of the body, they don't all have to be doing the same thing. There could be multiple compartments of the body that are all doing different things that are masking a pH discrepancy somewhere or adding to a discrepancy somewhere else. So don't get fooled on face value if the pH is normal. You still have to check all the compartments. That's what I'm getting at, and I'm going to explain that in just a second here. So what are the main players behind the pH buffering system of the body? Well, as a reminder, you have base excess. And these are in no particular order. The most important is probably the renal, but base excess. And so at any given time, your body is adapting plus or minus 2 to 0 to 2 to make minute-to-minute changes in the hydrogen and OH negative concentrations in the body. Because if you're left with a hydrogen on, you get an acid. If you're left with OH negative, you get a base. So when there's more base, it's going to shift one way. When there's more acid, it's going to shift the other way. And it's going to make these minute-to-minute corrections depending on if you're active, not active, what your diet is, the temperature. All these things are going to contribute to what your minute-to-minute pH is in your body. And then through the kidneys, primarily, and then this minute-to-minute base excess buffering system, your body's going to try to maintain homeostasis between the 7.35 and 7.45. Now, it's important to remember that although you have a respiratory component, which might only take seconds to minutes or hours to activate, I'm sure people have probably heard instances of diabetic ketoacidosis patients, quote unquote, blowing off acid. It's true, because CO2 in this bicarb buffering equation, when you get rid of CO2, what happens at the cellular level in your body is that you excrete hydrogen ions in so doing. So you will become less acidic. The reverse is true. If you hold your breath, you will become more acidic, respiratory-wise. So you do have respiratory, and there's things like Winner's formula, or if you can do like what your bicarb is, plus 15 times 0.6, whatever. There's a bunch of rules and calculations. It doesn't really matter. All you have to do is determine if there is a pH balance issue, and then is there a compensatory mechanism at play? And if so, is it compensating for it or is it not? And so that formula is CO2 plus H2O, and this could be written either way, and they go left to right or right to left, becomes carbonic anhydrous, becomes bicarb, and then hydrogen, your acid. And as a quick reminder, I drew these columns. I talked about cations, anions, the majority of the cations being sodium, the majority of the anions being chloride, so negative charge on the anion, positive charge on the cation. Then you got, I included potassium, but then you got all the other positives over here, calcium, magnesium, and then even all of the small ones that you get in your diet, zinc, copper, whatever, those all contribute to the positive charge of the body. And so in addition to your body wanting to maintain pH, the other thing that it wants to do is it wants to maintain electroneutrality, and that is very important. I would say the primary thing is probably to maintain the pH, and then the secondary thing is to maintain electroneutrality. So you can imagine that if you have a pH balance problem, the first thing that's going to get shifted is hydrogen to correct the pH problem. And it's going to do that at the expense of moving ions, positive or negative, depending on if you're acidotic or alkalotic, to then balance out the charge. Because if you move a bunch of hydrogen from one place to another, you have changed the concentration gradient, so you've changed the relative charge on each side, so then you need to fix that. And you're going to take the easiest ion to move, that takes the least amount of energy, and is most water soluble, and that's most plentiful to rectify the charge. So that is sodium and potassium. Those are the easiest ones to move. You're not going to send over albumin and phosphate and all this other big stuff to rectify the charge, because those are huge molecules, not very water soluble. And then of course you have your anion gap stuff up here, things like lactate. Anyways, so positives, negatives. I'm not saying they have to equal 0, but there is, there's a strong anion difference. Remember I said in that other video it was like 38, something like that, around 40. You have to stay in that parameter. If you add negatives and this number goes down, you got to add positives to bring it back up, and vice versa. So that's that. So your body's going to make minute-to-minute changes using its base excess and its bicarb buffering stuff, and then it's going to activate within seconds to minutes the respiratory system if it needs to. The respiratory system will stay activated long-term as well, I guess until you get tired. And then the last component is the renal, and this is the most important. Now, let me divide the body into cavities, because you can have acidosis in one cavity and alkalosis in another cavity, acidosis in 3 cavities, alkalosis in 2, acidic urine, electrolyte imbalance here. It's very, very complex. So the key is to not get fixated on a hydrogen ion here or there. It's to identify what the source of the problem is and then fix it, and then make sure that when you're fixing it, you're not making anything worse. So if you're going to give somebody sodium chloride and they already have a normal chloride, you might not want to do that. If your patient is only a little bit acidotic and you can treat infection, you probably aren't going to want to give bicarb, because the rebound effect of that after the acidosis goes away is that they're going to be persistently alkalotic. Now, I'll tell you, the average mortality rate of patients in the ICU or post-surgical patients who are admitted who have alkalosis, alkalosis is more common than people realize. Acidosis brings people to the hospital, but alkalosis is a lot of the times a secondary problem that commonly arises in ICU patients. With a pH that's 7.65, I'd say, somewhere around there, or greater, your mortality rate it's probably around 60% or greater. I don't remember from the exact study, but you can look this up if you want to. Vice versa, a lot of people recover from acidosis from 6.9 to 7.1. Now let's do the difference. Let's say 7.4 is the middle. How far down do you go here? Well, you went like 0.4 to 0.5 down this way. And up here, you only went like 0.2, 0.25. So the mortality rate doubles with half of the pH change compared to acidosis. So essentially, alkalosis is twice as bad in terms of mortality as acidosis is if you plus or minus the pH to the left or to the right the same amount. If you plus or minus the pH by 0.2 to the left or 0.2 to the right, the mortality will be higher in alkalotic patients than it is in those acidotic patients around 7.2. So it's a lot more difficult to correct alkalosis than it is to correct acidosis if you're not careful. So let me go through the, I guess, components of the body. So components, we'll write those here. This is how I view it. You have the blood, which we already said I'm going to call that extracellular fluid. So that could include the interstitial fluid and all this other stuff, lymph. And then you have intracellular, so the cells. And then you have the kidneys. I like to think about these separately because you can have acidosis in one, alkalosis in the other. So renal. Because the renal system really is the body's primary way that it buffers acids and bases, gets rid of bicarb, retains bicarb. 80% of the bicarb in the body is retained by the kidneys. So there's the most amount of specialized cells that are transporting sodium, potassium, hydrogen, chloride, bicarb back and forth. There's more of those in the kidney than almost anywhere else in the body. So there's your components. Now over here, we have acidosis, alkalosis, respiratory. I guess you could add respiratory over here as one of those components if you wanted to. Yeah, let's do that, because that is a space. And then metabolic. And then you have mixed. So take any combination, 1, 2, 3, 4, add them together in as many combinations as you possibly can. You don't need to be a rocket scientist to do the math and know that there's a lot of different possibilities. You can have ECF and ICF having acidosis but having a metabolic alkalosis. You can have, so plus or minus and combine these any which way you want. That's how complex the acid-base discrepancies are or can be in the body. And then you add all of this to electrolytes and fluid status or volume. So that's the whole picture. Extracellular, intracellular, what's going on in the kidneys, what's going on with the lungs. Is it acidosis, alkalosis? Is it respiratory, metabolic, or mixed? Is there a compensatory mechanism? And if so, are there electrolyte derangements? Are the electrolyte derangements causing the acidosis or alkalosis? Or is the acidosis and alkalosis causing the electrolyte derangement? Or is it a true electrolyte derangement, such as you're vomiting hydrogen chloride and actually losing chloride? Or has your volume changed? Are you contracted or expanded? So contracted is low volume and expanded is high volume. And then you get a relative hyperconcentration or relative hypoconcentration, depending on what your fluid status is. So all of this is really, really important. So how are you going to test for this stuff? Are you just going to take an ABG and say, okay, pH is 7.2, give them bicarb, don't test anything else, and then let's hope their kidneys work in 2 days from now? Of course you wouldn't do that. So let's talk about how you test for this stuff, and then I'm going to go into some examples. So briefly, let's talk about what happens the majority of the time. Here's a blood vessel. Here's another blood vessel. This side is going to be acidosis. And this side is going to be alkalosis. So there's going to be less hydrogen ions for alkalosis and more hydrogen ions for acidosis. Remember we said that the primary thing you want to do is fix the hydrogen ion concentration because cells don't like to operate outside of their normal pH environment. The cell function will not work as well, or the cells will die, and then eventually that'll progress to end organ damage, multi-organ dysfunction syndrome, and then death. So these cells, yeah, there's hydrogen, potassium, chloride, calcium. That stuff's floating in the cells, out of the cells, extracellular, interstitial space, in the blood. I get it, but for simplicity, I'm going to say I'm just drawing where they're most common. So if you have more hydrogen ions in alkalosis in the cell than you do in the blood, they are going to shift. So they're going to go from the cell into the blood. Bam. Now you've normalized the pH. So the body is saying, I'm happy. Likewise, here, let's get rid of a couple of these. You've normalized them. So in this instance, hydrogen goes into the blood from the cells. In this instance, hydrogen goes from the blood into the cells. And then now you have to balance the electrogradient. So what's the easiest thing to move? Well, it's not phosphate. It's not big proteins, albumin, or anything like that. It's not lactate. It's potassium and some sodium, probably. Sodium potassium pumps that kind of like, work both ways. So in here, since you've now made the inside of the cell way more positive, some of that positive's got to give. So what's going to come back into the blood? Potassium. So now in this blood, you have hyperkalemia. So let's take your standard example. A renal failure patient, because in the kidneys, you hang on to sodium, you excrete potassium in the urine. It's kind of how it goes. And then you hang on to water. If your kidneys aren't working, then you're not secreting potassium, so you're getting hyperkalemic. Hyperkalemia will cause acidosis the same way acidosis causes hyperkalemia. If you add a ton of excess potassium in here, the potassium will start to try to go into the cells, but eventually it'll be way too outnumbered, and then hydrogen will have to start coming out, and then you'll get acidosis. So over here, the reverse is true. You have hypokalemia. Because now by adding hydrogen from the cell into the blood, you have made the inside of the cell less positive. So positive charge is going to go from the blood into the cell to try to balance out that electrogradient, and you're going to be hypokalemic. That's about what happens a lot of the time, but it's not all of the time. You can have acidosis and have hypokalemia. You can have a bunch of electrolyte disturbances, because if you have an electrolyte, let's say one pH imbalance gives you hypokalemia and the other gives you hyperkalemia, but you have both at the same time. Well, couldn't your potassium then be normal? Probably. So don't get hung up on true, or sorry, not true, but just pure numbers, because there's a lot more that probably meets the eye. So now let's talk briefly about the kidney and why these cells are this is some complex stuff. So you have the glomerulus, you got the collecting ducts and the distal and the proximal convoluted tubule and the loop of Henle with the thick and thin descending and ascending limb, and then the collecting duct, and then out into the bladder eventually. You have specialized groups of cells maybe this part of the kidney is best at reabsorbing sodium, and maybe this part of the kidney is best at reabsorbing chloride, and maybe this part of the kidney is best at absorbing water. I made that up. There's I don't remember because I haven't looked this up in a while, and it's not important, to be honest with you. Some parts of the cell of the nephron of the kidney have specific functions more than others. So let's just talk about a couple of the functions of the cells. So you get all these ion exchangers is what they are called. So like in the proximal tubule or wherever, you can get a sodium hydrogen pump. So sodium hydrogen. So let's say you're trying to maintain sodium in water vicariously, because water follows sodium. You're going to excrete potassium in the urine. Okay? So reabsorb sodium, excrete hydrogen. Likewise, if for whatever reason you reabsorbed hydrogen, you're going to excrete more sodium and more water than you're going to be dehydrated. Let's see. What else do we have? Sodium bicarb. Everybody's probably heard of sodium bicarbonate, but you got sodium. To get sodium bicarbonate, you have to have sodium and bicarbonate on the same side, because it's a co-transport. So those are going to send those over and become sodium bicarbonate, and that's actually how the kidneys excrete bicarb when there's too much of it. If there's too much bicarb, it's going to bind to sodium, and then it's going to go. And again, this requires water, because nobody pees out powder. It's got to be diluted, otherwise you would, that would negatively affect your urethra, and then that's excreted. Oh boy, let's see. Okay. Sodium. What else is there? Potassium. Hydrogen potassium pump. Potassium. Hydrogen. And then what else is there? Chloride and bicarb. So chloride, bicarb. And I'm not drawing these in any particular order. Or like, I'm not calling this the tubule lumen, or this the blood. It's just these go in and out depending on what the electron gradient is on one side versus the other, and then depending on what the needs of the body are. It's really that simple. So let's break this down a little bit more, but then kind of summarize it to be more generic. Obviously, if you have derangements of hydrogen, that's going to affect sodium. If you have derangements in bicarb, it's going to attach to sodium, and then water is going to go through that or be involved in that to get excreted in the urine. If you have, if you're retaining all the sodium, the body might kick out hydrogen. Generally, what happens is it kicks out hydrogen and it kicks out potassium, and then reabsorbs sodium. And then it's the biggest buffer for bicarb, and it mainly uses chloride. So let's give an example of why hyperchloremic conditions cause acidosis. Remember, I drew those tubes, and then I said, like, your strong ions, sodium, chloride, and then we kind of gave the depiction that, oh, this is pressing up against the bicarb, so bicarb's got to go somewhere. That's a good way to visualize it, but what's actually happening is you have added chloride, okay? And then when that excess chloride gets to the kidney's going to perceive that as being hypervolumetric, or having a normal or high volume. So we're classifying these as being normal to high and normal to low volume. Okay, so if you're, it's like if you're driving 50 miles an hour on the interstate and you're seeing a tree every 10 seconds, and then all of a sudden you started seeing a tree every 5 seconds, you might think you're going faster, even though there might just be more trees. So there might just be more chloride ions, but your kidneys don't know any different. You're seeing now twice as many trees, so you think that it's moving twice as fast, so you think your volume's increased by twice. That's really all that's happening in the nephrons here. So if you increase drastically this chloride side, well, it's going to push this way. And what's that going to do? That's going to excrete bicarb, right? So when you lose bicarb, you get acidotic. So let's just a little gentle reminder here. Acidosis is either an increase in hydrogen, but it could be that your hydrogen stays the same, but you lose bicarb. So this is acidosis. And then alkalosis, you lose hydrogen or you increase bicarb, or both, right? So acid, base, or alkalosis. Okay? So all you have to take away for this crap, I guess you would call it, is that there's a lot of complex stuff that goes on in the kidneys. There's specialized areas that have specialized transporter cells that handle the reabsorption and the excretion of hydrogen, sodium, bicarbonate, potassium, and chloride are the main ones. If you have a type of kidney disease that affects one part of the kidney over the other, and a certain group of these cells are affected, or if you have a genetic condition and maybe your body just has a hard time with bicarb, then you could get an acidosis or an alkalosis just from that, right? If your kidney is hanging on to hydrogen ions and then excreting a bunch of bicarb, but the hydrogen is just kind of staying within the kidney, that would lead to a renal tubule acidosis because there's a lot of excess hydrogen in the kidney, but your urine would then be alkalotic. So you take a urinalysis of that patient and you'd be like, oh, the urine's alkalotic, they must have alkalosis. Not necessarily true. They could have a renal tubule acidosis caused from any number of things, and then you might check the pH of their whole body, and their pH of the body might be normal because the buffering system has kind of worked. So that's an example of how you can have an acidosis in the kidney, a normal pH in the body, and then an alkalosis in the urine. And then pick any other combination you want. It's all probably possible. So, alrighty. I'll go one more page here, I think, because that's all I have for paper. Save the turtles. So, now where do electrolytes come into place? Just like I drew here, if you disturb the hydrogen or the bicarb on any one of these sides, there will be a concomitant change in the electrolyte that corresponds with that. Potassium, chloride, calcium to a smaller degree, stuff like that. So where are we getting all of these ions? So not only can you have hydrogen and bicarb problems causing your pH derangement, you can also have electrolyte problems causing the derangement because it's pushing that transporter one way in the kidney versus the other, and it's either excreting or hanging on to hydrogen or bicarb, respectively, to a degree that's not normal, and then you develop an acidosis or an alkalosis somewhere in your body, or multiple places in your body. So let's just kind of break this down. You swallow food, you get most of your electrolytes in through your food hole, down your esophagus, and then your stomach has a specialized layer of cells that protect the lumen from erosion because the stomach has hydrochloric acid. Blamp. And I don't know what the stomach acidity is. It's like 2, maybe 3, something like that. I kind of made that up. You see how I'm kind of generalizing this, and it's like not really important to 100% memorize. It's just more important to get the concept. It's what we're after, right? So you satiate, your body starts breaking down the food you eat with saliva, and then you get the signals from the brain that says, ooh, I'm hungry. Start salivating and start eating, and then start releasing hydrochloric acid to a greater degree in the stomach to break down this food. Well, it can't go into the duodenum, the jejunum, and the ileum because that doesn't have the specialized lining of cells. So it's got to mix with something there. Well, what's going to neutralize that acid? Bicarb, right? Bile, all that kind of stuff. So you get these stomach acid and these peptides mixing with an acid mixing with a base to neutralize it, and then your food bolus becomes hydrologically, I don't know, acidically neutral, or not neutral rather, but in the range that the environment calls for, whether it's 6 or 5.5 or 7.1, I don't know, whatever. Either way, it neutralizes it. So if you have too much stomach acid and the bicarb can't keep up, you get an acidosis from that. If you don't have enough stomach acid, or you lose it somehow, like vomiting, and then all you have is this bicarb, where is that bicarb going to go? It's not just going to sit there and change the pH of the lumen. It's going to get absorbed back into the extracellular space, right? And then eventually it'll make its way into the blood, and then it'll go to the kidneys, and then the kidney is going to detect an increase in bicarb. So this is an example of vomiting. Let's just say you all of a sudden vomit profusely and you lose all of your hydrochloric acid. You can surmise that, okay, I have literally lost hydrogen. And hydrogen, in a way, is simply acid, right? So you can say, I have simply lost hydrogen, therefore I am now alkalotic. That's one way to do it. The other way to do it is how I just explained on the other page with the chloride. You've lost chloride, so now let's go back to it. I don't have the chloride necessary to send this bicarb out into the renal tubules to go out in the urine. So what am I going to do? I'm going to collect bicarb. And what's that going to lead to? That's going to lead to alkalosis. So vomiting causes alkalosis, right? And dehydration. So what's going to happen when you dehydrate yourself? Your RAS system is going to get activated, renin, angiotensin, aldosterone system. So what's aldosterone going to do? It's going to signal your kidneys to hang on to sodium and water to maintain your blood pressure, and it's going to excrete potassium. That's the process of urination and fluid retention. So through vomiting, you are going to become alkalotic and you're going to become hypokalemic. So this is an example of a hypokalemic alkalosis caused by metabolic issue. Now, so what's going to happen when your body in your whole blood, because eventually this is going to, eventually your body's not going to be able to compensate, the buffering system's not going to work anymore, so eventually your blood is going to be alkalotic. Okay? Now, what's going to happen then? Well, you still got cells, right? Now your cells are going to react. Because now, relatively speaking, in comparison to the blood, the cells are actually acidotic. Or acidic, I mean, sorry. You know, your cells haven't changed anything, but now there's a disproportionate amount of hydrogen ions inside of the cell than there are on the outside of the cell. Right? So you have a relational, I guess you could call it, acidosis inside of your cells compared to the blood. Anytime the blood is alkalotic, your cells are relatively acidotic. Anytime the blood is acidotic, your cells become relatively alkalotic, right? Just like if you lose bicarb, you become acidotic, whereas also if you gain hydrogen ions, you become acidotic. It's a two-way street. If one side's becoming alkalotic, the other side's becoming acidotic. If one side is losing positive charge, the other side is becoming more positively charged in comparison. It's always a two-sided thing. That's the complexity. So what are your cells going to do? Your cells, because now they're perceiving themselves as being acidotic, are going to actually produce bicarb. Cellular respiration. They're going to and then what happens when the level of bicarb on the inside of the cell through cellular respiration exceeds the level of bicarb on the outside? Just concentration gradient. It's going to diffuse back, and then see this cascading thing? See how complex this is? Compartments don't necessarily talk to each other because it's atoms and molecular level cellular stuff going on here. The point is, you could have a change in your stomach that then went into your blood, that then went into your kidney, that then made the kidney worse to try to hang on to water through aldosterone, that then caused relative cellular acidosis that then inadvertently produced more bicarb and then made your systemic alkalosis worse. So, don't ignore your patients that say they have nausea or who are vomiting, okay? So, anyways, sorry, continuing. So let's just dial it back, get a little bit more basic here. You're throwing up hydrochloric acid, so you're losing volume, and you're losing hydrogen, and you're losing chloride. We've explained that because you've lost chloride, your body is no longer able to use the chloride bicarb pump to excrete that chloride in the urine, so you get an increase, bicarb, so you get a relative increase in bicarb in the kidneys. That causes alkalosis. We then said that because you now have a fluid deficit, because your body is going to try to pee out all this excess bicarb, that's going to require water. But you're also losing fluid by vomiting. So in a multifold way, your volume status is going down. Right? So now you're dehydrated. So this is volume contraction. Now, in all of this, what changed? Your acid, your basis changed, but what electrolyte is abnormal? You lost hydrochloric acid, chloride. So you have to fix the chloride and the volume. So you have to give this patient volume and you have to give them chloride. So what do? Give them isotonic sodium chloride, 0.09% sodium chloride. Give them isotonic sodium chloride. The chloride will replace the chloride that they lost vomiting, and then the fluid will replace their fluid deficit. Their RAS system will stop the aldosterone, and then the dilutional effects, because now you have a higher concentration of bicarb related to the fluid, so that will actually help. Just changing the fluid will help your pH as well. Okay, if you have 2 units of bicarb in a liter of fluid, that's a lot of fluid for the bicarb. But if you have 2 units of bicarb in a milliliter of fluid, this seems a lot more alkalotic than this does in relation to how much fluid you have. These molecules are closer together in space because the space has contracted. So this is more alkalotic. If you took a pH, this would give you more a higher pH reading than this would. So you correct the volume status, you might fix some of your pH, right? So this is why it's important not to just blast your patient with sodium or chloride or bicarb or lactated ringers or you name it without knowing why. Sure, can most patients tolerate 250, 500 cc bolus? If they're profoundly dehydrated, yeah, that would probably be a good starting point, kind of no matter what your patient's like, unless they're a baby. You don't want to give a half a liter to them. But even heart failure patients can generally tolerate a couple hundred cc's, okay? And believe it or not, you might think a fluid overloaded patient from renal failure or from heart failure is fluid overloaded, but the fluid's actually not doing much. It's third spacing. So their actual blood volume that's getting pumped by their weak heart, it's actually slowing the blood flow. So they're hypertensive because their heart's trying to contract against more pressure, but the fluid's moving slower. So the kidneys perceive that as a low volume state because now there's less trees passing it over time. Maybe you're passing a tree every 20 seconds now, but you've gone slower, and you haven't gone slower. Somebody's just cutting trees down, and you're like, I'm dehydrated. So that's all. The kidneys don't know that your heart's not pumping. It just knows that it has stopped detecting as many chloride ions as it did before, for example. So you fix the heart pump, you then will get blood flowing through the kidney at a normal rate again. And then the kidney will stop reacting as if there is a contraction or an expansion of fluid, and then the kidney will start behaving normally again. Unless they have kidney failure on top of that. So, treat the underlying cause, right? So let's summarize. Actually, I'm not done explaining the GI system here. You absorb all of your electrolytes through your diet. Sunlight, vitamins, all this other stuff. So what are some big ones? Magnesium, calcium, sodium, just one plus, sorry, and potassium. Those are the big ones. Then you got albumin that's pulling water, and then you got a bunch of H2O. Okay? All going down your gut, mixing with the acid and the base, respectively, to neutralize the pH. Then it's going through your small intestines. All those nutrients are getting absorbed into the capillaries on the epithelial lining of the GI tract. And then it's taking in water, and then all the waste products your body doesn't need turn into a big giant thing of poop, and then you poop it out. But what about when you have diarrhea? Right? Maybe your GI tract is moving so fast that the stomach has not even emptied into it. So that bicarb's waiting, and then instead of receiving the food bolus, you're just having watery diarrhea. So it's washing that bicarb down, but what else is it taking with it? What else isn't going to have time to absorb? All those electrolytes. So you're going to get low potassium, low magnesium. You're going to get electrolyte deprived over time. And in patients that are chronically prone to this are alcoholics, for example. So what's the problem in this if you have uncontrolled diarrhea for too long? Well, we said before, hydrogen and chloride leaving causes acidosis. Alkalosis. Bicarb leaving, just like I drew on the other page, is going to cause acidosis. But what else did you lose? You lost potassium. So this is an example of a hypokalemic acidosis. See how you can have a hypo or a hyperkalemic acidosis or alkalosis? So don't get fixated just on the pure pH by itself or the pure electrolyte volume number by itself. Get fixated on all of it together. So here's what's most important. Let's summarize. Go to a new page. Your body wants to maintain what? pH. And obviously temperature is important too, but we're not getting into that. So your body wants to maintain pH. Hydrogen ions. Get an increase, it's acid. A decrease is base. Likewise, decrease in bicarb, acid. Increase bicarb, base. Right? The body is going to attempt to shift electrolytes and hydrogen, respectively, to neutralize the pH and then also to balance the electroneutrality. Electroneutrality. So pH, ion gradient. Yeah, those are the two big things that your body's going to try to reestablish. What are the main mechanisms that it does this with? One, renal. Body's biggest acid-base buffering system, renal. You saw all the cells that are specialized, that are responsible for the excretion and reabsorption of hydrogen, sodium, potassium, chloride, bicarb, and then you get like other stuff like what is it? NH4, ammonium. That's obviously excreted in urine too. But what's important about the kidneys? You get the renal tubules, all the cells, you get the blood. The important thing here is these need to maintain an electron gradient as well. Not an electron gradient, sorry, an ion gradient as well. If you get too many positives on one side versus the other, they're not going to shift appropriately. And that is going to affect two things. That is going to affect your urination, and that is going to affect the acid-base balance. So renal is the biggest component driver of acid-base in the body. But the quick reaction is your buffer, your base excess. So using that bicarb buffering equation, the carbonic acid. And then the third one is respiratory. Yep. So got to maintain pH, got to maintain ion gradients. Renal is the biggest component of the body to regulate the acid base and reabsorb and excrete ions and buffering things as necessary to maintain the body's pH and to maintain the body's appropriate amount of fluid or volume as well as electrolytes. But what's the other source of electrolytes that we have here? How do you get those electrolytes to begin with? Through your diet and metabolism. So anything that affects your respiration could change anything else here. Anything that affects the kidneys could change anything else here. Anything that affects your buffering system, like you administer bicarb to your patient inadvertently, would affect all of this other stuff. Multiple compartments in the body can have acidosis or alkalosis at the same time. So don't get fixated on your acidosis or alkalosis in one part or the other. Test it all. You could have a part of the body that leads to a decrease in one ion and another part of the body that leads to an increase in one ion, and those two cancel each other out. So by the time you take a blood test, maybe the value is normal. But there's still bad stuff going on in there. So how are we going to solve for all of this? What are we going to test for? Volume. The patient's volume. Signs and symptoms are important, right? Because that's going to let you know, okay, the patient's having chest pain. This is probably not. I mean, I suppose you know what I'm saying. They broke their arm. Yeah, that's not a chloride issue, right? So volume. So check the blood pressure. But then when you get into actual lab tests, check specific gravity in the urine. So also check a urine test. Specific gravity. Glomerular filtration rate. So pretty much, is there kidney failure? And then also check the heart and the kidneys. Is there a true fluid problem, or is there a pump problem or a kidney problem? Okay. You want to check the heart, do an echo. Okay. Shoot a chest x-ray. You want to test the kidneys? Check your GFR. Ask the patient when the last time they urinated is. Put a Foley in and look at the urine color. Okay? 3, all of your electrolytes. Keeping in mind that your electrolytes, your hydrogen, your bicarb, all of that will be off if your fluid volume is off. So what's an example? I talked about contracted state. So what's an expanded state? Somebody that has like a normal volume. People have primary aldosteronism, syndrome of inappropriate antidiuretic hormone release, people that have like genetic abnormalities, Addison's disease that are just releasing cortisol and stress hormones, renin, angiotensin, aldosterone, all that stuff's kind of like firing on overdrive. People that are having unopposed sympathetic nervous system activation, spinal injury maybe. Those patients might have hypokalemia because their body is, let's just say they have aldosteronism, where they're just secreting too much aldosterone. Their body is going to maintain sodium, water, and it's going to excrete potassium. So you're hypokalemic, you are hanging on to water, so you're becoming normal, if not expanded, in the amount of volume you have in your system, and these patients have normal or high blood pressure. Obviously, your contracted volume patients are going to have normal to low blood pressure. So if your patient's got electrolyte abnormalities and they don't have kidney failure and their blood pressure is normal or elevated, and you do an echo or shoot a chest x-ray and their heart's not enlarged, what's going on? Check for a tumor, right? So the more you go down this rabbit hole, the more you're going to have to address your questions. So starting basic, what are the vitals? What are the signs and symptoms? Do they look depleted, or do they look like they have enough fluid, or do they look like they have too much fluid? Check a basic metabolic panel and get electrolyte numbers. And And then, so now, just with those three things, you have the volume status, you have the GFR, so how the kidneys are functioning, you have all the electrolyte values, and then you've taken a look at the heart or the kidney as necessary to see if there is a disorder in one of those organs. Okay? Or the patient will tell you, yeah, I have genetic abnormality XYZ. And then you're like, well, I haven't looked at that since medical school. I'm going to go look it up. And you're like, oh, would you look at that? That causes the patient to retain a ridiculous amount of chloride and then just excrete a crap ton of bicarb, whatever it is. And then I guess 4, let's see, check the patient's volume, check their heart, their kidneys, check their electrolytes. Oh, and yeah, their ABG and pH. And then so how are you going to treat all this? Underlying cause. Now, I gave this other example of aldosteronism, primary aldosteronism, because that patient's going to have a normal chloride level. You wouldn't want to give that patient chloride. If their chloride's normal, you don't want to give that patient sodium chloride. You got to fix the thing that's causing the aldosterone. I don't know what aldosterone blockers are. Not my wheelhouse. But anyways, you got to address that problem. So, I mean, you might even have to dialysize those patients while giving them, lactated ringers, for example. I don't know. The point is you fix the underlying cause. You don't just jump right to one treatment modality versus another, because if your patient has some electrolyte abnormalities that you didn't check, and you start, blasting it with sodium chloride, this might make it worse. Okay, you might just give them now a hyperchloremic acidosis on top of their aldosteronism. That's not going to help them, is it? You just caused an iatrogenic component to their illness now. Congratulations. And you might not even ever have known it, and the patient might have just kind of fought it off their own or gotten lucky. We're not trying to get lucky here. We're trying to say, what is the problem? How do I fix it without causing further derailments to the left and the right? And we know that if it's a primary fluid problem and we fix the fluid, that the electrolyte and the pH might start to normalize. Likewise, if we know that they truly lost chloride by vomiting, you have to give them chloride, sodium chloride, to replace their volume, okay? Then check their pH. I'm sure it'll be normal after that, after you do that, right? They're no longer going to have the hypochloremia. So that's kind of it in a nutshell. So brief little summary of it all. Acidosis and alkalosis can be present in multiple parts of the body at the same time. You could have a compensation as well, respiratory or metabolically, that mask the pH in one direction or the other. There could be 3 components or compartments of the patient's body that all have derangements, and that's not really producing anything super out of the ordinary on your lab results. So keep testing, because we know that the kidneys are important, the blood is important, the respirations are important. So put your patient on an end-tidal, do stuff like that. Check an ABG, and then are they eating normal, or do they have something has your patient been in the ICU for 6 days without eating anything? They're probably going to have electrolyte abnormalities and pH problems just from that. Is your patient normally have COPD with a high respiratory acidosis, and they've been intubated for a week, and now they have a low CO2 compared to normal, so now their kidneys start producing bicarbonate. So now does your respiratory patient that normally had respiratory acidosis that you took away by cutting the respiratory rate in half, now you gave them a respiratory acidosis, and then now they got an acidosis in the ICU, and now they're going to try to compensate that by adding more bicarb. So now you got all these things fighting, and do you think this patient's in fighting shape? No, that's why they're in the hospital to begin with. That's what's really important here. What's the volume? What are the electrolytes? what's the pH, how are the organs doing, and then if I'm not getting any results, check more stuff. Check a urine chloride. If it's high or low, might tell you if their volume contracted or volume expanded. Treat appropriately. Check for toxins. You know, on the acidosis side, we got mud piles. On the alkalosis side, we get anything that is creating an alkalotic salt, right? Here's one for you. Last little confusing thing, right? When you give a patient, when your patient develops lactic acid from anaerobic metabolism in their cells, that is part of the anion gap thing we talked about on the other lecture. Lactic acid builds, it pushes out bicarb, and you become acidotic. But what about the patients that are chronic alcoholics and have chronic lactic acid built up because their cells don't function normally because they're always intoxicated? What about those patients? Well, what if they've been an alcoholic for 20 years? Do you think that they're just persistently acidotic? Or do you think maybe at some point the body is going to, like the kidneys specifically, are going to try to correct for that? Yeah, it's going to try to correct for that. So your kidneys might start to turn all of that lactate into alkalotic salts. And what happens then? Well, now all that lactate has transitioned into your body excreting the lactate and making organic salts, and then alkaline salts, and now your alkalotic. Now your alcoholic patient, who's probably also dehydrated, has a bunch of electrolyte abnormalities, volume depletion, and an alkalosis, and you have no idea why. And then you take their lactate and it's super elevated, and you're like, well, they have a lactic acidosis, right? See how confusing these things can really, really be? That's why you're adding it all together, and then you're not just being like, oh, I'm a brand new advanced EMT and I can do an IV and their blood pressure's low. Here's 3 liters of fluid, right? Same thing with nurses, same thing with physicians. Nobody should get away or be excused from knowing how complex the body is, how all of these systems all work together, and when you get a plus on one side, you get a minus on the other. You're going to have pluses and minuses all over the place, constantly opposing each other, and you could have multiple derangements present at once. You could have a COPD patient with chronic respiratory acidosis that just starts vomiting. Now they have a metabolic alkalosis on top of a respiratory acidosis. And then their pH goes up, for example, compared to what it was at its baseline. And then their kidneys are like, oh, I don't like that. And then they start to do all these changes with bicarb and urination. And then the patient just gets really, really, really sick. And then, then let's just say in the next 4 days, they don't eat well. Then they have electrolyte derangements. Yeah, so you never really know minute to minute, second to second, what's actually going on at the cellular level. It's just important to know what is causing the derangement. If I fix the underlying cause, the primary cause, will that make positive changes in the other electrolytes and pH stuff? And if not, then you got to consider that there's something else going on, and then you have to address that secondary problem. So that's it. All right.